Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the diseases of the umbilicus. Umbilical cord is formed in the second month of fetal life from the day from the body stalk. It is composed of water's jelly and is covered by ectoderm. It contains allantois. Allantois is the diverticulum from the yolk sac is a narrow tube passing from the cloaca through the umbilicus and umbilical cord to end blindly at the placenta. The part within the body forms the urachus and the bladder except the trigone. The remainder disappears. Vitellointestinal duct. The vitellointestinal duct is a tubular outgrowth of the yolk sac from which the gut is derived. By the time embryo is of 6 weeks, the vitellointestinal duct disappears. Umbilical vein. Originally, there are two umbilical veins, and the right one atrophies and disappears in early fetal life. The vein carries the oxygenated blood from the placenta to the fetal liver, where it is branched bifurcates to join the left branch of portal vein and to pass on as the ductus venosus to empty its contents into the inferior vena cava. Umbilical arteries. The umbilical arteries pass from the internal iliac arteries to and through the umbilicus and in a spiral fashion transverse the umbilical cord to join the placental plexus. Fibrous ring of the umbilicus. Fibrous ring of the umbilicus is situated in the blended aponeurosis of the linea alba at or below the center of that line. In early days of infancy, while the umbilicus becomes a consolidated scar, the structures just mentioned shrink into impervious cords except the section of the allantois which forms the part of the bladder. These cords diverge from the abdominal aspect of the umbilicus into the extraperitoneal fatty tissue and produce peritoneal folds. Upwards in the free edge of the falciform ligament runs the ligamentum teres, the obliterated umbilical vein to the longitudinal fissure of the liver. Directly downwards to the apex of the bladder runs the urachus, the obliterated allantois. Obliquely downwards and outwards pass the obliterated hypogastric or umbilical arteries to join the internal iliac arteries. Lymphatics. The lymphatic vessels drain into both the groins and both axillae. Infection of the umbilical cord in half of the infants born in maternity hospitals by the third or fourth day cord is found to be carrying staphylococci. Less commonly, the stump of the cord harbors streptococci E. coli and Clostridium tetani causing the neonatal tetanus or the other possible infections. The main prophylaxis is the strict asepsis during the severance of the cord and the daily use of 1% chlorhexidine jelly. Ophalitis. In communities where the aseptic severance of the umbilical cord is not practiced, the incidence of infected umbilicus is much higher. When the stump of the umbilical cord is inflamed, antibiotic therapy usually localizes the inflammation. The crust separate giving way to the pus by applying warm moist dressings. Exuberant granulation tissue requires a touch of silver nitrate. In more severe cases, infection is liable to spread along the hypogastric arteries or umbilical vein. Then one or other of the complications will supervene. Abs of the abdominal wall. When gentle pressure is exerted below or above the navel, a bead of pus exudes at the umbilicus. A deep abscess associated with one of the umbilical vessels is present. The treatment of choice is the opening of the abscess. A probe is passed into the sinus to determine the direction and is followed by grooved director onto which the skin and overlying tissues are incised in the midline. Excessive ulceration of the abdominal wall due to synergic infection and is treated by culture and sensitivity and using the sensitive drugs. Hyperbaric oxygen is, if available, can be of use for ancillary treatment. Septicemia. Septicemia may occur by organisms entering the bloodstream through the umbilical vein. Jaundice, it usually the first sign. The abscess in the abdomen above the umbilicus may be present. The treatment is in the routine lines. Jaundice in the newborn, caused by the infection reaching the liver through the umbilical vein, may cause a stenosing intrahepatic cholangitis, occurring 3 to 6 weeks after the birth. Portal vein thrombosis. Portal vein thrombosis may lead to portal hypertension. Peritonitis. Peritonitis carries a bad prognosis. If an abscess of the abdominal wall is present, it should be drained. If peritoneal fluid is accumulated, it should be drained by insertion of an intraperitoneal suprapubic drainage tube. Umbilical granuloma. Chronic infection of the umbilical cicatrix which continues for weeks causes granulation tissue to pout at the umbilicus. There is no certain means of distinguishing this condition from an adenoma. Usually the umbilical granuloma can be destroyed by one application of a silver nitrate stick followed by dry dressings. If it is adenoma, it soon recurs after treatment. Dermatitis of and around the umbilicus. It is common at all times of life. Fungus and parasitic infections are more difficult to eradicate from the umbilicus than from the skin of abdomen. Sometimes the dermatitis is secondary to the discharge from the umbilicus. As in case of umbilical fistula or sinus, a deep tender swelling in the midline below the umbilicus signifies an abscess present in the extraperitoneal fat. It is usually due to an infected urethral remnant. Treatment comprises of exploration and proper drainage. Pilonidal sinus. A sinus containing a sheaf of hair is sometimes encountered. The treatment is the excision of the sinus. Umbilical calculus. It is usually black in color, composed of desquamated epithelium which becomes inspissated and collects in a deep recess of the umbilicus. It gives rise to inflammation and often a blood-stained discharge. The treatment is to dilate the orifice and extract the calculus. But to prevent a recurrence, it is advisable to excise the umbilicus. Umbilical fistula. As the umbilicus is the central abdominal scar, that a slow leak from any viscous is liable to track to the surface at this point. In addition to that, occasionally the vitello-intestinal duct or the urachus remains patent. Consequently, it has been remarked aptly that the umbilicus is a creek into which many fistulous streams may open. For example, an inflamed enlarged gallbladder perforating at its fundus may discharge the gallstones through the umbilicus. Again, an unremitting flow of pus from the umbilicus of middle-aged woman led to discovery of a length of gauze overlooked during hysterectomy before 5 years. Vitello-intestinal duct. The vitello-intestinal duct sometimes persists and gives rise to either of the conditions. It remains patent and the resulting umbilical fistula discharges mucus and sometimes feces. A small portion of the duct near the umbilicus remains patent and gives rise to a sinus that discharges mucus. The epithelial lining of the sinus sometimes becomes everted to form the adenoma. Sometimes both the umbilical and the intestinal ends of the duct close, but the mucous membrane of the intervening portions remains and an intra-abdominal cyst develops. With its lumen obliterated or unobliterated, the vitello-intestinal duct provides an intraperitoneal band, which is a potential danger for intestinal obstruction liable to occur. The obstruction results from a coil of small intestine passing under or over or becoming twisted around the band. Such a band may contract and pull a Meckel's diverticulum into a congenital umbilical hernia. A vitello-intestinal cord connected to Meckel's diverticulum but not attached to the umbilicus becomes adherent to or knotted around another loop of small intestine and so causes intestinal obstruction. Sometimes a band extending from the umbilicus is attached to the mesentery near its junction with the distal part of the ileum. In this case, the band is probably an obliterated vitelline artery. It is not necessarily associated with a Meckel's diverticulum. Treatment of patent vitello-intestinal duct. The treatment of patent vitello-intestinal duct is the excision along with the Meckel's diverticulum, preferably when the child is about 6 months old. When a vitello-intestinal band gives rise to acute intestinal obstruction, after removing the obstruction by division of the band, it is expedient when possible to excise the band and to bury the contents. Patent urachus. A patent urachus never reveals itself until maturity or till old age. The contractions of the bladder starts at the apex of the organ and pass towards the base. The patent urachus, as it opens into the apex, is closed temporarily during micturition. So the potential urinary stream to the umbilicus is cut off. Hence, the fistula remains unobstructive until a time when the organ is overfull and due usually to some form of obstruction. Treatment of patent urachus. The treatment of patent urachus is directed to remove the obstruction to the lower urinary tract. If after this is remedied, the leak continues or a cyst develops in connection with the urachus. Umbilectomy and excision of the urachus down to the insertion into the apex of the bladder with the closure of the latter organ is indicated. Neoplasms of umbilicus. Umbilical adenoma or raspberry tumor. Umbilical adenoma is usually seen in infants and rarely in later life. It is partially or completely due to unobliterated vitello-intestinal duct. Mucosa prolapsing through the umbilicus gives rise to a raspberry-like tumor which is moist with mucus and tends to bleed. Treatment of umbilical adenoma. If the tumor is pedunculated, a ligature is tied around it and in a few days the polypus drops off. If the tumor reappears after this procedure, umbilectomy is indicated. Sometimes a vitello-intestinal duct or a vitello-intestinal band will be found associated with a Meckel's diverticulum. Here the Meckel's diverticulum and the attached cord or duct are excised as the umbilicus. Endometrioma occurs in women between the ages of 20 and 25. On histological examination, it is found to contain the endometrial glands occupying the same plane in the dermis as the pseudoriferous glands and opening onto the surface in the same way. The umbilicus becomes painful and bleeds at each menstruation. When the small fleshy tumor between the folds of the umbilicus becomes more apparent. Sometimes an umbilical endometrioma is accompanied by endometrioma in the uterus or ovary. If the tumor is solitary, umbilectomy will cure the condition. Secondary carcinoma. Secondary carcinoma at the umbilicus is also common, but it is always a late manifestation of the disease. The primary neoplasm is situated in the stomach, colon or ovary, but the metastasis from the breast is probably transmitted along the lymphatics of the round ligament of the liver is sometimes located here. That's all about the diseases of the umbilicus. And in the next video, I will discuss about some other disease. Thank you.